Okay, having a problem getting the slides to move. If we want, we can start over again. I'm not sure where the problem is with the settings. Oh, okay. Now I think we're there. Okay, how about I go back, we'll start over again. Okay, well, what I want to do now is go ahead and jump into the program that we've been offering for a few years here. The first thing I'd like to do is go over the discussion of what we think an emergency management program should be for a community health center. We always want to remind folks what it is that is important to them and why community health centers play a role. The community health centers, the vulnerable populations, and you all know this, but the populations that you serve are those that we see most at risk during disasters, and we've had quite a few down here. And I think Katrina was the #1 event where we had a lot of high-risk, uninsured, low-income patients get moved from Mississippi and Louisiana, and a lot of them ended up in Alabama. So we saw firsthand the type of patients that need a lot of care, and community health centers do that. And with our help with a disaster plan and some training, that helped them work through the issues prior to these events happening. And it's a huge population. These are those groups that we talked about, and there are a lot of those in Alabama. And if you look at the vulnerable populations of the uninsured, the poor, the rural, the community health centers as a whole have said with public health, with the right kind of planning, organization, resource management, they could conceivably manage up to 20 or 25% of the population of Alabama, which is in the neighborhood of 1 million people. So there's a huge role for community health centers, and we want to capitalize on what you all do. Now, the future role, nobody is quite sure, but I do know there's been talk about expanding the role of community health centers, increasing the numbers, and if that happens and as those numbers go up, I think just logically the percent of people who are going to be helped during the events, I think that will increase as well. We always like to start by defining where community health centers need to begin the process. We start with this center line across meeting the disaster and meeting the challenge. The hazard threat assessment, we think that HTVA is important because it sets the rules for those things you need to plan for. Tornadoes, obviously in Alabama, the terrorism events, although they're not likely or possible. We have problems with hurricanes. Center part of the U.S., the Memphis-St. Louis area is definitely prone to the earthquakes, as California. And then all the other disasters, including infectious disease outbreaks. Those things are all important for community health centers to plan for. And as they define their risks, then we begin this process up at the top of looking at the risk and the threats, go back and look at lessons learned. What have other people learned from past experiences, and help write plans and do some training based on real events. Those things tend to really stick with people. The commitment and leadership has never been a problem in community health centers. We want to stress incident command. We want to stress disaster planning. And the commitment and leadership of community health centers is always really good in Alabama, and hopefully that's everywhere. So that's never been a problem. The building a foundation of capabilities, tools, templates, that's where we really kind of step in and help. We see disaster plans that are in place. Some are good, some are not so good. We offer templates, guides, documentation that can be embedded into the plans. We help them with resources and supplies, and most definitely what we do is training on everything from biological, chemical, radiological, surge, all the way to incident command. I would say we've probably got currently about 14 to 15 topics that are available that build on this capabilities, tools, templates, and training, and that's where we can be a lot of help. The mandates and the legislation are those things that You know, there's two reasons why you do planning. One is it's the right thing to do. The other is someone says you have to do it, and that's where the mandates and legislation comes in. NIMS, Joint Commission, sometimes state and local requirements. We'll look at those, see what requirements you have, and make sure that we at least cover the minimum of what you should be doing. And really, these mandates and legislations are all intended to build on, because it's the right thing to do. So we don't discourage it. We just want to make sure that you know everything that we believe you're required to do. And then the last part of this circle is the collaboration and partnerships. That's probably the most important. We really believe that about 80 to 90% of disaster response is knowing the right people to call for help, and knowing that if you call them, they will answer and they will help you. Community planning, working with public health, emergency management, other healthcare facilities, EMS, public health, EMA, all of those folks build this collaboration and partnership. So all of this really is the foundation of everything that we go into those community health centers and offer them. Things that we ask them to consider, and a lot of places will say, well, we wouldn't do all of these things during a disaster, but unfortunately there's been evidence that you will do all of these, maybe not all at one time. Of course, you do manage your internal issues, potentially mass care. That's not something that you would do on a daily basis, but mass casualty care is possible. This sorting and triage, we have some examples of that. Helping hospitals with overflow, community health centers taking primary care, hospitals taking emergent cases, but that's that collaboration and the relationship building. All of these things, I could read them all to you, but you can see that there is a possibility that every one of these things would play a role in a community health center response. In Alabama, and I suspect everywhere, there are all types of facilities that would provide care during a disaster. And we saw in Mississippi and Louisiana, not very far from here, probably as close as 40 to 50 miles, we were seeing a lot of the temporary facilities set up. And the reason the temporary facilities take on such a role is that these permanent sites are either overflowing or damaged or not functioning. And in that permanent site are the community health centers. You have anywhere from one clinic to some agencies have 8 or 10 or 12. So whereas a couple of clinics might not be usable, the other 6 or 7 or 8 are. Sometimes the community health center staff will help over in these temporary sites for mass shelters, medical needs shelters. So again, this gets back to the collaboration. What can you do in your community? What sort of assets, capabilities do you have? Can you manage your own? Can you help in the others? And I think this whole picture has to be understood for everybody to relate best to each other. When we look at a program, there are 3 basic elements to an emergency management program, and each facility needs to consider these core elements of protecting the human resources, protecting your physical plant, and then this business continuity, meaning how do I stay open and continue to function. Those are universal for everybody. If you convert that over to a community health center, I think those 3 elements are protecting your staff and make sure they can come in and function and feel comfortable about being there. Protect your community health center patients. That's probably number 1. However, protecting your staff very well may be number 1, because if you don't have the staff, you can't take care of patients. But keeping your patients safe, providing the good continuous care, that really is the operations of the agency. And then continue to deliver that health care, which is your continuity of operations. We take these 3 components and build off of them to build this program. Also in that, we ask the community health centers to consider the 4 phases that everybody has to consider. The mitigation is, do you do pre-event planning? Do you put things in place to protect you when bad things do happen? This is the thinking ahead and the pre-planning piece. The preparedness would be something like a disaster plan, having training and exercises. Those things prepare you to respond, and that's a big piece of it. The response activity to me, I think sometimes winds up being the easiest part, because that is the healthcare piece. That's where you take care of the patients, you take care of patients like you do every day. The response piece might be difficult, but to me, I think it's probably the easier. And then the fourth stage that we have to factor in is the recovery, and really that's how you put things back. How do you return to that pre-disaster level? How do you get staff back on regular schedules? How do you get resources replaced? How do you put your buildings back? So these four phases are key to any emergency management plan, and I think it all applies to community health centers. Now the good thing is that all emergencies, no matter how big they are nationally or statewide or regionally, most of the time your involvement is very local. It's your little world. It's where we say it's limited in scope and range. Everybody, always used to say, well, every emergency is local. Well, that's because you see what you see, you do what you do. And the good thing is you are just one piece of this huge event. That then sort of limits how big and how bad it can be. If you're in the wrong place at the wrong time, those things do happen and it could overwhelm you. But the good of all of this is most of the time your level of involvement is somewhat limited based on population and where you live and who can come and help. So it's not nearly as dire sometimes as we make it out to be. So at this point, we always ask, where's your emergency management program? We ask about their plan. Do they have one? Have they started talking about incident command? Do they meet regularly? Do you have this in place, something that's reviewed once or twice a year, and just where are you? So at this point we'll take a break and then we move back into the next piece. Now today we're not going to take a break, but I'm explaining how we do our training at each site. So at this point we move over into this next section, which kind of gets into the NIMS, Incident Command, National Response Framework. This is where we talk about the things that you have to do. The NIMS program is a national incident management program that says you have to do things a certain way. Incident Command is the command structure everybody must have, and the National Response Framework is sort of like the national plan. NIMS, ICS, NRF, and the statement at the bottom, while it is not a requirement for community health centers at this time, compliance with NIMS is strongly encouraged. What that means is that for the last few years, hospitals have had to be compliant with NIMS, whereas community health centers have not. However, you notice on the bottom, changes as of July 1st, the new guidelines for NIMS have come out, and in the new guideline it says all healthcare facilities will. So I think we're going to see some changes as of July, where we might go from is strongly encouraged to is required, but that will define itself over the next few months, and I think as we get closer to July we'll have a better idea of what community health centers must do as far as optional or mandatory compliance. NIMS is the standardized system that says we want all response agencies to look and act and feel the same, this national approach, and really it's made up of 5 basic pieces that everybody must comply with. I hate to use the word comply, but if you want to have a good program, you have to kind of comply with the guidelines. Those 5 things are organizational structure, plans, training and exercises. Sorry about this. This word organization should be over here. I think we've just had the slides are off a little bit. But organizational structure, plans, training exercises, resources, communications, and technology. Every agency must do these 5 things, and this word here, organization, should be in this circle because that's what it implies. If you do NIMS correctly, every agency is organized and structured the same way. Meaning structure, incident command. You have an incident commander. You use this system during disasters. Everybody has a disaster plan, and the plan is consistent. Plans are sort of uniform from agency to agency. We all train and exercise on the same things, and we do this regularly, once or twice a year. Resources. Everybody has to understand how to manage their assets. I think the resources are probably the most vulnerable, and they are most likely to put you out of business. You can work around staffing shortages, you can work around your building, you can in some ways work around money. But if you run out of medical supplies and equipment and you don't have those things in your hand to provide care, that really limits what you can do. So I think it's vitally important. I think resources, even as much as command, plans, or training, maybe even more, the stuff that you have to treat people is absolutely critical. And then the fifth component is, do you have communications and technology that all other agencies use? You have to maintain that link. Our goal is to make sure that everybody does these 5 things to create organization. Now, the NIMS outline of the 11 elements, we don't have time to go through those today, but I've included those as of July 1st. And basically it talks about adopting NIMS, being NIMS compliant, and money and awards that you get, revising your plans, do you have mutual aid agreements, the training and exercises. And these are FEMA courses, 100, 200, 700, 800, that we encourage community health center folks to get. Do you apply NIMS and incident command to training and exercises? This is the play like you practice and practice like you play theory. Do you have the processes, equipment, data interoperability, terminology? All of these 11 things are consistent with the 5 components we talked about on the previous slide. These are the 11 principal elements of NIMS that at some point I believe there will be a compliance of these 11, and can you verify to someone that you've met all of these requirements. Maybe July, we'll see. Incident command is the structure that says how we're going to run our agency during an event. We talk about this at length because it's a very military police-like structure. It gives people this management system based on military and fire chain of command. You will hear these terms, military, police, and fire, a lot. Chief, officer, commander, those sorts of terms. And even though we're not used to these terms in healthcare, it helps us relate to all the other service agencies and response agencies in the community, so that when we do collaborate, we're using the same terms, references, names, ideas. It creates that uniformity, and everybody's using the same structure. It's just like in the military, there are ranks that are consistent across all branches of the service, and so if you call someone a colonel, you know what that colonel does and you know their position. And ICS creates somewhat of that same environment. It's terminology and structure, and you know who does what based on the fact that everybody's doing it. Incident command is critical. All of these characteristics we go over. We talk about the terminology, the modular organization, meaning what does your organizational chart look like? How do you manage an event by the objectives and come up with a working plan that's a live plan during a disaster? We make sure everybody understands chain of command, the unified command system where you actually go out and participate with other agencies. The span of control comes back up to your organization. How many people do you control so that you're more efficient with 2 or 3 people rather than 15 or 20? We talk about how you organize that way. Your emergency operations centers might be something familiar to you. It might be called a command post. This is where a group of people sit down either within your agency, within the community, work together to solve problems. They call those an emergency ops center, and we go into details there. The resource management piece, how do we manage money, buildings, people, supplies? How do we manage that and make it last? And when we start to run out, where do we get more? That's all part of incident command. And then the last piece is the information and intelligence that goes along with good communications. We could normally give our agencies a sample incident command chart, and these are not cut in stone, but they are suggestions based on what the incident command system should look like, the ops, planning, logistics, and finance pieces, the command section, who might take on these roles. So we get in, look at theirs. If they don't have one, offer this one for them to use, and then we'll go back and help build it out and make sure they put the right people in the right positions. all of this is great. You can have an incident command system within your agency, but if you don't use it to your advantage and build these collaborations and these relationships, I think you're not going to do as well. You're never able to do as well when you perform by yourself than when you do it with others in your community. Locally, you get the hospitals, health departments, EMAs, other healthcare facilities, and you all know who those people are and you work with them every day. But it's also helpful if you take it to that next level and you go to the state associations, the state hospital group, state community health center association, health departments, EMA. This allows you to get to that next layer of government that can bring in resources sometimes that you can't get locally. But it really is all focused on your state primary care associations. It's critical that they have a presence in the state. They know where everybody is. They can work with everyone. They can work with public health and EMAs and get you the support. They are sort of your state representative during disasters. And if you look down in the lower corner, this is a map of Alabama, and you can see where all of the community health center clinics are, and they're distributed out all over the state. And so you can see where if there is a state association representative sitting in public health or EMA, they have access to every one of these dots on the map and can help put resources in your hands and push them to you. So it's a vital link for us, and they do a really good job with this in Alabama. Well, that slide's all out of whack, but the National Response Framework is the sister document to the Incident Command System, and the important word here is coordination. Incident Command creates structure and organization. The National Response Framework creates coordination. The feds have a system now that says, now that you all look and act the same, we're going to put our system in place that offers up coordination. We're going to define who does what so everybody works better together. This is a slide that compares the two. NIMS creates this organizational structure. National Response Framework creates coordination. And really, the National Response Framework is that federal system that says if you run out of resources locally, you go up to the next level, maybe your county government. Those folks help you when you run out of resources at that level. Then you come up to maybe part of your state, regional, or half of your state. In Alabama, we respond north and south. And then once resources are depleted, then the entire state comes to your aid. Then you reach across borders to the next, those adjoining states, to regions of the U.S., and finally the peak of the pyramid is the federal government. That's the coordination piece that the National Response Framework puts in place. The nice thing is, it translates from the feds all the way down to the local, the same system, the same guidelines, the same principles, and that's what makes it efficient. In the National Response Framework, they have broken this down into, actually there's some places have 16 and some have 15. In these slides I put 16 because some states add an annex, but the emergency support functions, those are the responsibilities that are given to large departments or agencies. So for example, in the federal government, they believe that 15 or 16 annexes can provide all of the activities that are necessary during a disaster, during a response, and this pattern flows from the peak of the pyramid from the feds all the way down to the county level, and each governmental agency has this same structure in place, and we'll go over what those are right now. So in the national plan, Emergency Support Function 1, that is the transportation duties. So the Department of Transportation will do these things during disasters. It doesn't mean they do it all, they do some, they coordinate, but as far as Emergency Support Function 1, that falls to Department of Transportation. The one we want to get to is down here on the second page, Emergency Support Function 8. That is the Public Health and Medical Service. That responsibility nationally falls to the Department of Health and Human Services, and these are the things that they manage from a federal, state, and local level. Not all public health departments do all of these things. They do some, they coordinate, And those are the folks who are your first line of defense at the county level, those public health folks who are receiving guidance from the peak of the pyramid, which would be Department of Health and Human Services. So, in your county, you will find a county plan that mimics the state plan, that mimics the national plan, and each one of these chapters is written by that agency who's been given the authority to write Chapter 8, Public Health and Medical. And in your county, that's going to be your county health department, and you're going to find Chapter 8 in your county plan written by the county health department. And if you don't have a copy of this chapter, you really should, because that in all essence is your county healthcare response plan, and it's important to have that on hand so that it's accurate and you know who does what. And we spend much more time on these than we could do today. And you can see they go on through. Some have added support function 16, which is veterinary services. Some do, some do not. And this is that tiered response we talked about at the lowest level: county, parts of the state, adjacent states, and eventually the federal. And that is the tiers of response. And as you work your way up, you get more and more support from a higher and higher level of government. And it's important to understand how this works for you. The third section we talk about, and we'll just kind of go over these quickly, the Joint Commission Emergency Management Program requirements. Not all community health centers are Joint Commission accredited, but we will go over those. We'll talk about what the requirements are, what the standards are. And this is good to know because it really does give you a lot of good guidance on what your emergency management plan should have in it. These categories: emergency management, provision of care, human resources, these all follow right along with the NIMS requirements. A lot of consistency between them. So for those who are Joint Commission accredited, it's just one more step in the process of making sure you have a really good detailed plan. In the next section that we cover, we go over examples of community health center activities, and we do this so that people can understand just exactly what they might have to do. We hear all of the time, we would never have to do that. I can't imagine what we would have to do in a disaster. Do you think we would really have to do that? Well, we give them examples. The first thing, so that they understand what they might have to do, we suggest they do a really good hazard vulnerability assessment. We talked about that on the very first slide. What are those things that are in your area? What are you most at risk of? On the Gulf Coast, hurricanes, tornadoes, accidents, mass casualties, infectious disease outbreaks, those things that we sort of cheat the system and say we're going to plan for the things most likely. In California, they have earthquake planning. In Hawaii, I'm sure they have tsunami planning. So it's regional, it depends on what you have, and there's no sense in planning and putting priorities on things that you don't have. So that's the first thing we do to kind of get them to thinking, what might we have to do during disasters? Here's some local examples. Katrina hit. Within just a few days, there were probably 1 million people displaced, and the vast majority of them had chronic disease problems, and they ran out of their meds. So, within the first week along the coast, 15 healthcare sites were set up, seeing somewhere 1,500 to 2,000 people a day. And if you look at what they were seeing, some injuries, mostly minor, but the illnesses started to take over. GI, respiratory, skin rash, 20% was med refills. Post-Katrina, this was very quickly within the first week shifting to almost a primary care outpatient event, which then within the first month looked like this. 78% of the patients seen, almost 80%, were minor illnesses and chronic disease, which were med refills and reestablishing disease management. Who else does this as well as community health centers? So you see the role, and this happened from Mississippi to Louisiana and into parts of Texas, and then it started to present itself in other states where people had evacuated to, and all of a sudden they were taking these same problems from Louisiana to Iowa and Montana and California. So this is exactly why we think community health centers play a role. These were just things that they were seeing for that first month, and it's a lot of general illness and not the mass casualty trauma-like event that some people thought it was going to be. Another problem was in Louisiana, thousands and thousands of people were without any care, and there was one hospital over across the river from downtown New Orleans, West Jefferson, stayed open, and prior to Katrina they were seeing 300 to 400 a day. Post-Katrina, at one time it jumped up to 3,000 per day. So the hospital was on the verge of not being able to manage. In fact, they were really struggling to manage. So they took control of an abandoned nursing home across the street from the hospital. They put a DMAT in the parking lot, and then they worked with one of their community health centers in the area and said, how about we set you up in the nursing home, we'll provide resources for you, we'll triage out in the street, we'll take the emergency patients, the in-between category patients can go to the DMAT in the parking lot, and the vast majority can go across the street to the community health center. And if you notice, over just a short period of time, they triaged 200,000 patients by splitting up the load, working with their community health center, and it was a really, really big success. And it all gets back to community collaboration. And the primary care needs were taken care of. That's the way this is supposed to work, and that's what we push for. And every time we do this talk in Alabama, we use this example because it's a perfect way to expand services, to manage surge, and put patients in the right places where people know how to handle them the best. Another place community health centers could take a role on, it would be in communicable disease or infectious disease outbreaks. H1 was a perfect example. Primary care, outpatient, vaccination, pre-hospital, all of those things, expanding hours, increasing numbers of staff to handle this, and this was something that was discussed and planned in Alabama as well. So those are examples we go over with all of these centers, and it begins to make them think, what could we do in our community, what resources, what assets, and how do we collaborate. So we do that little piece that says, here's a reminder of just what you might have to do. Now I'm going to switch gears a little bit. Communications and technology, if you remember, that was one of the NIMS requirements. In Alabama, we have a system called the Alabama Incident Management System. It's an online information tool. It uses the term situational awareness, and this system is run by our public health department. If you remember, emergency support function 8 is managed by public health. Their job is to coordinate response, and part of that is information. So they gather information from all the healthcare facilities in the state. They do something with that data, analyze it, send it back, make decisions. They do the resource management support, help with supplies, equipment, people, and manage it from that highest level of government back down, and this is the tool that we use to do that. It acquires this situational awareness, and it's an information gathering tool. Every community health center has a secure login, and public health will ask them to enter certain pieces of data periodically during the day for a period of time, and it's very simple. Log on, enter the data, we will get the information, and then we will turn around and help you any way that we can. That's the best part of AIMS, is the help that it offers. Right now with our system, we collect information from hospitals, medical needs shelters, nursing homes, dialysis, all of these over here. Everything from hospital down are the data entry sites. These are healthcare facilities, if you'd like. The Emergency Operations Center modules, these are manned by state and area folks in public health and EMA. They absorb all the information entered by these people, make the decisions, and push the help back out. And you notice that community health centers in Alabama have their own login. And the nice thing about AIMS is it's free, it's never turned off, It's activated during disasters. They log in, enter data, receive information back, and it's really an efficient tool that you can use at your desk, at home, on your handheld device, your smartphone, anything where you can access the internet, you have access to AIMS. I'll give you a quick look at what the data entry module looks like. This is where you have your folks gathering important information and enter it into AIMS. You can put it in multiple points, you can put it in at one site, just depends on what you want. And the screen will, let me get to that screen. Sorry, that screen's not in here. It's a login screen that when you go to AIMS.org, the main screen will pop up and say your XYZ Community Health Center, please enter the following information. And sorry about that, I thought there was a slide in here. But it's their own private web page where they can log in and enter the data, and you can see here that it's monitored by Public Health and EMA. Very well received, and again, I apologize they don't have the main page in there. But I'd be happy to show it to you, just let me know. You probably have something like this available in your state. As we get towards the end of the day, we ask them now to let us look at what's within the components of their emergency management plan. What does it look like? Do they include all the right things? Have they included the NIMS requirements? Just what's in there, and is it a good plan, not so good plan, and we help them build those out. The first thing, again, we come back to this analysis. We'll help them with a hazard vulnerability assessment. If they've never done one, we'll help them with one. We'll give them the forms to do the assessments. We can point them to the people in their community who have access to the community hazard assessment. And it's really important that they know what their threats are so they can begin to plan off of the 5 or 6 or 10 things that they believe are the most likely to happen to them. When you do your hazard assessment, it rates what's the probability of the event, how are we going to respond, what's the human impact, property impact, business impact. You can't just check the boxes on these. You actually have to have people sit down, talk about hurricanes, talk about tornadoes. What's the probability? How bad might it be? What resources do we need? Internal, external, all of those things. And really a hazard vulnerability says these are the things that are most dangerous, and here's how well we are prepared or not prepared. These are the documents that we work off of. So for natural disasters, mass casualties, technological events, human events, we go through all of these. If they have them, fine. If they don't have them, we mark them off the list. And then we help them build their plans based on all of the things on this page that they're likely to have happen. And it becomes overwhelming at times because you really can't take too many of these things out of your plan, but you have to at least think about how would we do each one of these. And the example we give is your response to a tornado is completely different from your response to the flu or some infectious disease outbreak. Different equipment, different supplies, different drugs, different people. And so you have to be able to adjust, and to be able to adjust you have to identify your threats, and from those threats you build the specific parts of your plan that handles each one of those types of events. That's critical before you ever start writing your plan. We look at things like mutual aid agreements. Do you have agreements with others? Do you have an agreement with a hospital, with other community health centers, with nursing homes, public health? And you could even get into compacts and contracts. What about your vendors? Food, water, fuel. All of these things are important for a couple of reasons. One is agreements lay out the ground rules of who's going to do what, who's going to support whom. That's important that you know what's going to happen. The other is from a potential reimbursement financial side, mutual aid agreements, compacts, contracts, all of those things need to be in place before an event so that if you are eligible for reimbursement, the agreement spelled out specifically what you did and the agreements that were in place beforehand so that it helps speed up that reimbursement process. But that's a big if. You just don't know what you're going to be eligible for. Mutual aid agreements are a key part to your disaster plan. Other things that we go through, page by page. Do you talk about continuity of operations? How are you going to continue to run the business? If number 1 is not there, who's 2? If 2's gone, who's 3? What happens if you lose part of your building? Can you move to an additional site? What if you have half your staff? How are you going to work, and what are you going to prioritize? So that's the continuity piece. The command and control is instant command. We help build that out. How are you going to run your facility using command and control? We help with training and exercises. We lay out what we think they should be training on and exercising. And then going down the list, each one of these topics is probably a half hour to an hour discussion. So you see, this becomes a lengthy process when we go through their plan, making sure that they address all of these things. And I know that not everything is on this list. So this is a starting place for us to actually sit down, look at their disaster plan, and see if it meets the minimal list of all of these things. Somewhere, all of these things have to be in their plan. We have put together a disaster plan template. We've pushed that out to the community health centers. They have it. Some have said, can we just change the name and use it? Others have said, we already have a plan. We'll use it as a guide. We'll measure your template against ours. And I don't have any of the attachments, but that is available. If you would like us to send you a copy of this plan, we know that it's not perfect for everybody, but at least it's a template that says, here are all the things that should be in your emergency plan. Use it, or use it as a guide. Look at the plan, look at your plan, compare the two. Did you forget something? Did it make you want to add something? And again, we sit down with the centers and we help them through that process. We think it's the process more than the plan. We take their documents, look at our template, and help match it up to the best tool that they have. And a lot of them have been working on this, and the planning has gotten significantly better over the last couple of years. This is us. We are the National Center for Disaster Medical Response. Some of our folks remember us as the Advanced Regional Response Training Center. We started out purely as training, but now we've actually gotten into planning and response with the University of South Alabama. That is my email address, dwallace@usouthal.edu, and you can find us at that phone number. We are plenty busy within the state of Alabama, and it is a full-time job for us with hospitals, nursing home, community health center, public health, EMS, all of the traditional healthcare facilities, but we can always find time to help. If there's anything we can do as far as providing you documentation, doing some training, maybe train the trainer. There's no limit to people's imagination, so anything you have seen in this presentation, feel free to get in touch with us. We are more than willing to help, and we'll make ourselves available one way or the other. And I believe the last is our training center. This is a brochure of the classes that we provide, and those are free. They're provided free to healthcare professionals in Alabama. We'll pay their mileage, put them in a hotel. Anyone from outside the state of Alabama is welcome to come. We just can't provide travel costs for people other than those living in Alabama, but you're welcome to come, and you can find that at our website. These are the courses that we offer, and these stay consistent through the year. And again, if you go to our website, you'll see the calendar, the topics. We do post PowerPoints of each of these presentations, so they're available to you as well. That's where our information came from, just to make sure that you can validate the information that we're using. And I believe